So, hello everyone from around the world. This is Omid Moghaddas and Hot Seat, the third session. We have the pleasure to have Dr. Ehab Moussa joining us from United States, and I'm pretty sure 100% of you all know this guy. I'm so happy to call him my friend, and in Facebook, in Instagram, in lots of congresses, you can see his stuffs, his great presentations, cases. And at the beginning, I just want to say that if you want to know real beauty and art in regeneration, whether it's soft tissue or hard tissue, you can go on his Instagram page and then you will understand what I'm saying. So as a introduction, I wanna have Ehab Moussa as a CV for you. He obtained his bachelor degree in dentistry from the Faculty of Dentistry, Alexandria in Egypt in 2009, and then in 2012 he joined the Periodontics Fellowship Program at Case Western Reserve University in Cleveland, Ohio. Afterwards, he pursued a master's degree in periodontics and joined the residency program at the same university. Recognizing the importance of sound prosthetic principles in surgical practice, he commenced the fellowship program at Louisiana State University in New Orleans, Louisiana, and now he has a full-time private practice position in New Orleans. Also, he gives lecture around the world, so many great courses. So I'm pretty sure you will enjoy his presentation today. And again, I'm so thankful that he accepted my invitation for this hot seat session. And the topics today are going to be unraveling implant site deficiency, where to start. At the end, we will have about 10-minute discussion. So I'm not going to wait too much longer. And Ehab, the platform is all yours.
Hey man, thanks again for having me. I really appreciate it. It's always a pleasure to chat with you. And again, thanks again very much for having me and for thinking of me to include me in this program. But right now I'm not full-time in private practice. I'm full-time at home at the moment. So this is just one one adjustment over what you said. But again, this is going to be a very type of informal presentation, just sharing, my thoughts on severe implant site deficiencies. And again, let's get going. The topic is unraveling implant site deficiency, where to start. So, just a little bit about myself, like you already mentioned, I did my dental school in Egypt, Alexandria, Egypt, which is where I'm from. I practiced with my father, who's a prosthodontist and still in practice. I practiced with him for a couple of years. Following that, I moved to Cleveland, Ohio. This is where I did my periodontal training. Following that, I moved to New Orleans, which is where I'm currently at. I did 1 year of implant prosthodontics and currently in private practice here in New Orleans. And, if you've never visited Alexandria, Egypt, or New Orleans, here are just some of the some photos from both of these places. On the left-hand side, you can see some photos from Egypt. On the bottom, this is Alexandria. This is where I grew up. On the right-hand side, this is New Orleans, and you see, the Mardi Gras images, all the festivals. So both really unique cities in their own ways. And, once all that we're in right now is over, I would urge everybody to take a trip over there, and I'm sure that they're going to enjoy it. So, we're at a very unique point in time right now for the whole world. There's just so much uncertainty, so much, I want to say, worry on everybody's mind, businesses at risk. But it's very, very easy to get caught up in all of that and, look at this in a very negative way. And, it's when I talk to someone, it's a day by day type of thing. But before going into the topic, I'd like to share some of the things that just help me to get by, day by day, help me to keep a positive outlook. And you know, always maintaining a positive attitude is going to be something very important. You know, not thinking of this as some sort of lockdown, but, you know, it's time to, you know, spend some more time with the family. Get that checklist that you've been putting off for months and months, you know, crossing a few items off of that checklist. One of the things that really helps me is just, you know, staying active and staying productive. You know, exercising in whatever way you can, um, working on some lectures, you know, working on your Instagram, working on your Facebook, just staying in touch with dentistry. And obviously, you know, trying to self-reflect and become better day by day. You know, just use that time wisely. And again, it's not an easy process. You know, it has its ups and downs, but I felt that I want to share these few points which kind of help me just get through these difficult times. And you know, it's we live in a time where we're very fortunate, and everything is really available at our fingertips. Um, we don't have to lose track of dentistry. I know dentistry is such a big passion for all of us, and even though we're all staying at home, you know, you see a ton of webinars, you see a ton of discussion online, and so I applaud you and I applaud everybody else that's taken this initiative. And we're really very fortunate to be in a time where, even though we're at home, we can still learn, we can still discuss, we can still continue to follow our passion through dentistry. And so, you know, without further ado, the topic for today is looking at implant site deficiencies. And, you know, what we're looking at today are cases where you don't need to do only one type of procedure, but you may need to do several procedures, several hard tissue procedures, several soft tissue procedures to get to where you want to go. And the question that we're trying to answer today is, you know, where do we start? And we look at a case like this. This is a patient that I treated back in residency. You know, this patient presented with a severe vertical deficiency in the posterior maxilla. You know, we went ahead and treated this patient with a vertical bone augmentation procedure. Here you see a lateral window done simultaneously. We're gonna go ahead and try to grow some bone vertically. We use a titanium reinforced barrier here. This is a mix of allograft and xenograft. Membrane is stabilized buccally and palatally. And here you can see the post-op CT, nice bone formed within the sinus, nice vertical bone levels. You know, we wait about 6 to 7 months in a case like this. We go back in using denser drills here, place our implant in position. Here you see the at time of the placement, and this is the post-op PA. Moving on to second stage surgery, where we do this with a free gingival graft. And this was the last time I saw this patient. This was back in 2014 or 15, okay? So, you know, a few months back, I get a phone call from this patient, and, you know, he's saying, "Hey, Dr. Moussa, I heard that you're in New Orleans, and you know what, I'm in New Orleans too, and guess what, I need more implants. Can I come and see you?" And so, you know, the first thing you think about is, how's my implant doing 5 years later? And so he comes in to see me, and this is 5 years later, and you can see that the implant, which is the first molar here in this case, is holding up well. There's nice tissues on the buccal. The tooth behind it, the second molar, is probably not doing so well, and we ended up taking out this case. And you know, you see a patient 5 years later, vertical bone augmentation, and the first thing you think about is, you know what, I need to get a CT scan. So we go ahead and get the CT scan, and you know, I was pleasantly surprised to see that we have adequate bone height and adequate bone width on the buccal and on the palatal of this implant. But you know, the question is, are all cases like this? Are all cases this stable at 5 years post-op, at 10 years post-op, at 15 years post-op? And I'm sure that in your practice, you see a ton of cases like what you see here up on the screen. And you know, when we see cases like this in our practice, the first thing we think about is, you know, what's the cause here? How did we get to this point in time? And when we look at the factors, you have several factors that may be involved. Definitely peri-implantitis, plaque-induced peri-implantitis, occlusion may be a factor. implant placement. We're not sure if these implants were placed within the bony housing, outside the bony housing. Definitely the patient may not be doing what they're supposed to be doing on the hygiene side of things. You may have some systemic factors that are in the mix. Smoking may be an issue. But the two factors that I would like to focus on with today's presentation is insufficient hard and soft tissue volume. When we place implants and we finalize our cases without the sufficient hard and soft tissue volume quantity and quality wise, we put our implants at increased risk for hard and soft tissue loss. And this is what we're going to be discussing throughout the rest of this presentation. And so our objective for today is looking at cases, cases that involve multiple procedures, multiple soft and hard tissue procedures, and being able to put these hard and soft tissue procedures in the correct sequence that allows us to be successful in those cases at the end. And so we all know where the problem starts. And this is a landmark study for all of us by Araujo and Lindy. And it's really very simple. You take a tooth out, you start losing bone height and bone width, more particular so on the buccal aspects. And there's nothing that you can really do to stop this process from happening, with the exception of partial extraction therapy, which I'm sure Howie's going to talk about a lot in his next webinar with you. But this is the process, this is the cause, and this is what leads us to get to this point in time, where now we're dealing with large bone and soft tissue deficiencies. And so again, when we're looking at cases like these, where do we start? And this is going to be what we're going to focus on for the remainder of this presentation. Well, first of all, we need a plan, right? And like Scott Gans always says, it's you either you need to plan ahead so that you don't fail. And this is what we're doing here. We need to develop our plan. And when we look at our cases, developing a correct plan really depends on two main things. Analysis and diagnostics, being able to look at the factors the patient presents with, systemic factors, local factors, and being able to diagnose these accordingly and develop a treatment plan, And the second factor that it depends on is going to be following a correct treatment sequence. So you still hear me fine?
Yeah.
Okay. So when we look at analysis and diagnostics, we have a few factors that we look at. First of all is the systemic factors. What does this patient present with? What's the ASA status? Is this patient a diabetic? Is this patient a smoker? Any autoimmune diseases that can affect what we're doing? What sort of medication like bisphosphonates that can affect what we're doing? And when we look at, the systemic factors, I think this is a factor that we sometimes overlook, or we put it into our presentations just for the sake of completion. But here I show you two patients. These two patients present with less than ideal hard and soft tissue conditions. But when we look at the systemic factors, when we look at the history of those patients, on one end, you have a 50-year-old patient. She's a non-smoker. She's ASA1. She has a long life ahead of her. This is her first time seeking implant placement. And on the right-hand side, you have a gentleman that's been through subperiosteal implants that have failed. And then he's went through root form implants that have served him for several years. And these later failed. And he's basically on his third round of implants. But he's 84 years old. He's a moderate smoker. And he's got some systemic diseases that can affect what we're doing. And so when we look, again, at the heart tissue for these two patients, again, less than ideal for both of these patients. But am I going to follow the same treatment plan for these patients? Should I look at the patient who's 50 years old on the left-hand side, chop off 10 millimeters of her bone, and perform an all-on-X type of procedure for her? Well, I don't think so. I think that in this case, we really need to look at the systemic factors and the history, and this is what's going to dictate the treatment.
On the left-hand side, this is a young patient. She has a long life ahead of her. And so I'm not going to chop off her bone. I'm not going to put her in position to be, that if this set of implant fails later on, then she's stuck with, not even a denture. She's not going to be even able to wear a denture. So we're going to go with a titanium mesh augmentation, traditional route, build the bone, place the implants, restore the case. While on the right-hand side, this patient, he's 80-something years old. And he doesn't have the time and he doesn't have the mental capacity to go through, 1 full year of regenerative surgery to place the implant. So we're gonna flatten the bone, place implants, perform an all-on-X procedure. And this is how both patients leave the office. The patient on the left-hand side, she has a million stitches in place. She can't wear her denture for 2 to 4 weeks. Life is gonna be hard for her, throughout the next year or so. While the patient on the right-hand side, he leaves with an immediate fixed provisional that's supported by implants. And so when we look at total treatment time, it's 1 year on the left side and it's 3 to 4 months on the right-hand side. But again, that does not mean that every patient that walks into my office, we're going to treat with an all-on-X procedure. No, the systemic factors, the history, all of these factors have a big role in dictating the treatment plan. So we've talked a little bit about the systemic factors. Now, when we go and look at a local site level, the first thing that we really want to look at in our analysis and diagnostics is going to be the soft tissue. What's the attachment level on the neighboring teeth? Is this a case where we may require some ortho extrusion, as we've been shown by Salama Brothers and the Atlanta team? What's the vestibular depth? If you look at this photo on the screen, this patient's lip is pretty much attached to his crest of the ridge. And look at that strong lingual freedom. There is no way that I can perform a bone augmentation procedure with the soft tissue condition as is. As soon as this patient leaves, as soon as his lip moves, everything is simply going to open up. We also look at the keratinized gingiva width and thickness. Well, if I have a thin biotype, like what you see on the screen here, well, I probably don't want to use something like titanium mesh, which puts me at higher risk of exposure. I may think of another technique, or I may think of thickening that gingival biotype before proceeding with surgery. What about soft tissue volume? We all need to close over these bone graft materials. We need primary closure. So if we look at this photo here, where we just removed an implant and this patient has a fistula on the buccal side, well, if I perform my bone graft at the same time, I'm starting out with a negative soft tissue deficiency. I not only need to advance my flaps to cover the bone graft, but I also need to advance my flaps to make up for the soft tissue deficiency I'm starting with. So this may not be the best time to perform the bone graft. We may opt to perform a soft tissue graft or let the socket heal, then go ahead and do the bone graft. What about scarring? You see if in this photo here, this patient has already went through a bone augmentation procedure, and you see the type of adhesions and you see the type of clefting that you can get after those procedures, and those make flap advancement and primary closure so much harder. And we may opt to perform a vestibuloplasty or some sort of procedure first before going ahead with the bone graft. Also, soft tissue clefting. This is a patient that has a cleft in his soft tissue, and this is something that we probably want to manage first before we opt to go ahead and manage the hard tissues. And so we look at the soft tissue conditions, and we may find that we have soft tissue conditions that are well and good and allow us to proceed with hard tissue first. But we may find that we have one of these scenarios, and based on what we see here, we can choose one of multiple different soft tissue procedures to help us correct the soft tissues first, and then set ourselves up for success to proceed with hard tissue. And we're working right now on an online course that's hopefully going to be online within a week or so. And this online course, what I love about it really is soft tissue is probably one of the most innovative parts of implant dentistry. And in this course, we're covering all of these techniques that you see up on the screen in step-by-step detail that you can view online and probably practice on a pig jaw while staying at home. So we've talked about the soft tissue on a local site level. Now we move on to the hard tissue. And this is a very nice classification. There's a ton of, as you know, there's a ton of defect site classifications out there for bone grafting. But what I love about this classification is it really looks in depth at the type of defect that we're looking at. And it usually looks at only the first three factors. The first three factors I'll talk about, but I've added an additional fourth factor because I feel it has a lot of importance when we talk about hard tissue. So first of all, are we trying to grow bone vertically? Or are we trying to grow bone horizontally? There's a big difference. We need to find out which defect orientation we're dealing with. How much bone do we need to grow? Are we trying to grow 1 millimeter of bone? Can we use something as simple as a collagen membrane? Or are we trying to grow 10 millimeters of bone? And this is when we need to break out those complex techniques so that we can accomplish our goals. Third of all, and really most importantly, is the relation to the alveolar envelope. Are we trying to grow bone within the confines of the envelope, like you see on the top photo here? Or are we trying to step outside the confines of the alveolar envelope, which is so much harder, like you see in the bottom photo here? And this is the area where I modified this classification a little bit, and it's how many teeth or how many sites are we treating? Are we trying to grow bone in a single tooth site, which is gonna be much more simple compared if you're trying to grow bone in a multiple tooth site or in a full arch case, for example? Other factors that we need to consider here is, are we trying to grow bone buccally or lingually or both? That's going to affect our position for the implants, and it's going to affect the technique we choose. It's going to affect where we place our tacks and our screws. The interproximal height of bone, again, as we have been taught by Team Atlanta, is what's going to save us. If we're trying to grow bone vertically, well, that interproximal height of bone on the neighboring teeth is what really dictates how much vertical bone you can gain. Third of all is bony walls. The more bony walls that you have, the more blood supply that you have, the more containability that you're going to have in those defects, and really the more simple the defect is going to be to treat. Last but not least is site vascularity. Are we dealing with a 1 millimeter thin ridge that's composed only of cortical bone that really ultimately provides almost no blood supply to our graft? Or are we dealing with something that has multiple walls that can vascularize a particulate graft very easily? And so, when we talk about hard tissue, after we look at those factors, we need to look at the techniques that we're going to utilize to treat those defects. And personally, in my own practice, the 4 techniques that you see up on the screen are going to be what I utilize in 90% of the cases. I'm a big believer that each one of us, we have to go out, learn new techniques, apply them. But at the same time, we need to have a few techniques that we're especially proficient at, techniques that we perform a lot, that we practice a lot, and therefore we can be more successful at because we've repeated them so many times. And so what I utilize in most of my cases is going to be ridge expansion or ridge splitting, GBR with resorbable barriers, titanium mesh, as I know you're also a big fan of, and last but not least is the Corey technique with a few modifications of its own. So this is a decision tree that I had presented in Dental XP meeting a couple of years back. And this is a decision tree that outlines where and when we can utilize each one of those techniques based on the defect morphology. So when we look at horizontal ridge augmentation, we're breaking that down into single tooth, multiple teeth, and full arch. When we look at single tooth, if you have a ridge that is 3 millimeters or more, you can be very successful utilizing ridge expansion with or without GBR or veneer grafting. When you look at an internal defect that's confined within the envelope, well, GBR with a resorbable barrier can be very successful and a very low risk procedure. Only when we go into those external defects, when we're looking at those defects where we're stepping outside of the confines of the alveolar envelope, this is where we need to use the rigid space maintenance like titanium mesh and Corey techniques. We look at multiple teeth. Well, again, if we have a ridge that is 3 millimeters or more, now that it's a multiple tooth defect, we may opt to do a ridge split instead of an expansion. Internal defects, again, you can be very successful with guided bone regeneration, keeping the risk of the procedure down. External defects, again, this is where we break out our rigid space maintenance techniques. When we look at full arch, we're breaking those down into mild to moderate defects and severe defects. In mild to moderate, my preferred technique of choice is either going to be ridge expansion with GBR or ridge splitting with GBR. You know, in cases where we can't get the implant in, then it may be GBR with delayed placement. And when we look at something as severe as what you see on the right hand of the screen, well, this is definitely going to be something that we need to break out our titanium meshes or Corey technique on. Now, moving on to vertical ridge augmentation, and this is a simpler classification here. We're breaking it down into mild, moderate, and severe based on how much bone we're trying to grow. Only in those mild cases where we need to grow 1, maybe 2 millimeters of bone, where I'm going to consider utilizing guided bone regeneration with a resorbable barrier, perhaps adding in a small tenting screw. But I would say that for most of the other defects, I am a fan of titanium mesh. I feel that it lends itself to handling and to shaping in those 3D defects very well. So we've talked about the factors the patient presents with, how we analyze them, how we diagnose them, and how those can lead us to choosing a particular technique, whether it be hard or soft tissue. But now that we've chosen those techniques, the second part of developing a plan is going to be putting those techniques in order and developing a treatment sequence that sets us up for success on every phase of our treatment. And when we look at treatment sequence, this is a very simple flow chart that I think, you know, simplifies the process and goes through it step by step. Well, first we start with soft tissue analysis, like we've shown. And that is, of course, after systemic patient factors are analyzed. When we look at a local level, we start with the soft tissue analysis. And well, we may look at the soft tissue and we may find that, you know what, this patient has soft tissues that, you know, are procedure. And at the other hand, we may look and we see that, you know what, this patient needs a soft tissue augmentation procedure first. Regardless, whether we move to the hard tissue or the soft tissue augmentation procedure, we will get to the hard tissue analysis on step 3. When we look at the hard tissue analysis based on the defect morphology, we go ahead and perform a particular technique to grow the bone that we need to grow. Hopefully everything goes well with that and that site heals, you know, uneventfully. Then we proceed with the implant placement. We let those implants heal for 3, 4, 5, 6 months, depending on how much time we need. And after implant placement is a step that I really feel is a very underlooked step in implant dentistry, which is stage 2. Stage 2, I feel, is one of the most important steps that we have in our treatment plan. And this is the point where we look at our soft tissue and we decide, do we have the adequate soft tissue quality and quantity to proceed with second stage surgery? And based on what we find, you know, second stage surgery may be something as simple as, you know, a punch type of incision, or it may be something as complex as, you know, a lingually positioned flap with a labial-free gingival graft. And so let's look at a case that kind of shows how we go about this process step by step. So this is a patient that presented to our office. You know, I don't have the CT scan on here, but I can tell you he has a severe vertical deficiency in the anterior mandible. So we analyze the soft tissue. You know, we see that there is 0 vestibular depth on the buccal. There is a very strong lingual frenum. And there's no way that I can advance these tissues, the amount of advancement that I need to close over a vertical bone augmentation procedure. And so what are my options here? Well, I know that I need to deepen the vestibule. We can perform a vestibuloplasty as a sole procedure, or we can perform a vestibuloplasty with a free gingival graft procedure, which is what I opted to do here. So we suture the vestibule as apical as we can on the buccal. Free gingival graft is sutured also as apical as we can. And here you see about 6 weeks after the soft tissue augmentation procedure, we have more vestibular depth. And this is now a time where we can proceed with the hard tissue procedure. One note that I'll mention here is that these free gingival grafts tend to be, they're composed of very dense connective tissue. And so between the soft tissue procedure that we do and the hard tissue procedure, we need to allow enough time for that tissue to vascularize. Otherwise, we risk spontaneous necrosis in areas of that free gingival graft. So we have soft tissue conditions that are good, and we're ready to proceed with the hard tissue. This is how it looks like once we flap the area. And looking at this on the screen here, we have a true vertical defect. You have both a buccal and a lingual component. And for something such as this, again, based on the classifications that we went through, titanium mesh is going to be the technique of choice for me personally. We're going to go to the chin, harvest some autogenous bone using this ACM drill, which is really one of the best tools I've used to collect bone. We're going to mix it with xenograft in a 50-50 ratio, in this case here. And then here you see the titanium mesh stabilized in position. We have good interproximal heights of bone that can support our mesh in position. Here I'm using a combination of tacks and screws on the buccal and on the lingual to stabilize that mesh. Here you see the screws on the lingual. We covered that mesh with a collagen membrane. Again, this is a step that, the literature is divided on. You'll find people that have been successful without collagen membrane on top of it, on top of the mesh, and people that have recommend placing a collagen membrane. Personally, I feel better with layering the mesh with a collagen membrane on top, a non-cross-link barrier. Here you see PRF over everything to help with the soft tissue healing. And this is the final suturing for the case. Now, in a case like this, we're waiting about 6 to 7 months at least before we go back in. And when we go back in, we see that we have adequate bone height, adequate volume that can now allow us to place our implants in a restoratively driven manner. So that's going to be the next step. We use denser drills here. I'm not using these drills in reverse. I'm using these drills in forward motion. I'm not sure what these drills are going to be doing to a grafted site in reverse. And so I'm using them in forward motion. Implants go in place. And then after the implants go in place, we let those heal for about 3 months, okay? After 3 months, and this is what I'm talking about by stage 2 analysis, really, really a critical step here. And here we see that we have a little dehiscence of the cover screw with the implant on the right. But when we look at the soft tissues for this case, well, we have plenty of keratinized gingiva on the labial because we did a free gingival graft in the beginning. But when we look at the lingual aspect, and if we outline the position of the implants on the screen, and then we draw a line across the lingual mucogingival junction. Well, if I proceed with a punch type of incision here, I'm going to be left with really the bare minimum of keratinized gingiva on the lingual. And that's not really my goal. My goal is to maximize the amount of tissues that this patient is leaving the office with. And so instead of performing a punch type of incision design, we have so much keratinized gingiva on the crest of the ridge, on the labial aspect of the ridge. And so what I'm going to do is simply move all that kg that is covering the crest of the ridge to the lingual aspect. And so we're going to perform a lingually positioned flap here. And so that's what you see here in this case. Incisions extend just labial to the implants. It's a partial thickness incision crestally on the lingual aspect. And as we get deeper, it turns into a semi-blunt dissection, where we're basically using our periosteal elevator just to basically push those muscles down. We suture the flap to the periosteum on the lingual aspect, and this is how it heals up. And here you can see that we've managed to form, I would say, adequate amount of kg on the lingual aspect of those implants. We have attached gingiva that's going to protect those implants long term. And here you can see the final screw retained bridge for this case. Now, we talked about both processes. We talked about the analysis and the diagnostics. We've talked about the treatment sequencing and the treatment planning for the case. And so I'd like to go through a couple of more cases that show how we can implement those processes into daily clinical practice. And so here's a patient that presents with, severe, not severe, I would say a moderate horizontal deficiency in the posterior mandible. But when we look at the soft tissue, we have a very narrow band of keratinized gingiva. But we do have adequate soft tissue thickness. And so I don't feel that keratinized gingiva width is something that needs to be addressed before the bone graft. I think this is something that we can better address after the implants are in place, where we can better judge where we need to graft that KG. Is it on the lingual? Is it on the buccal? Is it on the crestal aspect? And so at this point in time, we're ready to proceed with the bone grafting procedure. This is how the ridge looks upon flap elevation. Anteriorly, it's in a much better condition than posteriorly. And the way we're going to manage this case is with a ridge split procedure combined with a GBR. Now, I don't really perform ridge splits that much in the posterior mandible, but in this case, I think it was indicated and it worked out pretty well. So we use a piezo. We're performing our crestal cuts, and then we're performing 2 vertical cuts mesially and distally. Now we're trying to, prolong or make our cuts to make our segment longer than we need to minimize the chances of fracture. Our crestal cut is going to be more towards the lingual aspect. We're biased towards the lingual. And so here you see the cuts connected to each other. And here you see the implants in place in a subcrestal fashion, as we have always been taught. And then we graft the internal aspect of the defect using an allograft here. And, a lot of people are comfortable with, just layering PRF over this, but I feel that this segment on the buccal is so unpredictable, especially when we're working in the mandible, that we need to cover this with a GBR procedure. And so we're using a collagen membrane here, a mix of allograft and xenograft. Collagen membrane is stacked in position to contain this graft really well. And again, when you're working in the posterior mandible, people like Van Urban have taught us how to release that lingual flap so well that it's really made primary closure in the posterior mandible so, I don't want to say easy, but so predictable. Long time ago, I used to dread the day of, performing a bone augmentation procedure in the posterior mandible. Now, closing over that bone graft with the aid of the lingual flap release is really so much simpler than before. And so primary closure is what we achieve here. And here you can see the post-op scan for this patient. Now, we let this heal for about 5 months. And then we go back and we perform our second stage analysis. How are we going to uncover this case? And when we look at the crest of the ridge, well, we have a very narrow band of keratinized gingiva. Well, looking at this here, this band is definitely too narrow to split between the buccal and lingual. We're just not going to be left with enough. This is one option, but I don't think it's going to work out. A second option is that, and this is something that Radoslaw Jadash performs a lot, is performing a free gingival graft, letting that heal, and then coming back, splitting that KG width into buccal and lingual. But then we're turning the second stage surgery into 2 different procedures, not just one. Another option may be moving that band of KG that we have to the lingual aspect and using a free gingival graft to graft the buccal all at the same time as we uncover the implants. And that's what we're gonna proceed with in this case. So here you see we start first with an apically positioned flap on the buccal. This is all in mucosa. So we're taking that mucosa and we're positioning it apically in a partial thickness flap. Excuse me. And then we take that KG that we had at the crest of the ridge and we move it to the lingual aspect of those implants. And so now what you see here on the screen is that the labial flap is sutured apically. periosteal bed on the labial aspect is prepared for a free gingival graft, and the KG that was once at the crest of the ridge is now lingual to those healing abutments. We go to the palate. In this case, we go to the edentulous ridge, and this is one thing that we discuss in our course, and it's really, you know, not all harvests need to be painful harvests. This patient is missing teeth on her upper left upper left quadrant. And so there's no reason for me to go to the palate. I can go to the edentulous ridge, harvest a very thin free gingival graft, and actually this patient had zero trouble from the donor site during healing. So we harvest our graft, we go to the buccal aspect of those implants, we suture the graft in position as per normal free gingival graft suturing, and this is how the case heals up at about 4 weeks post-op. And you see that we now have a good band of KG on the buccal aspect of those implants, and on the lingual, we really have the minimum required band of KG on the lingual aspect, but we still have some sort of attached gingiva, a deepened vestibule that you know, gives those implants a better chance at long-term stability. So I'll move on to one final case that I would like to show today. And this is a patient that, you know, you see this full mouth photo and you can immediately notice where the problem's coming from. His lower incisors, lower central incisors are basically in trouble. And we take a look at the radiographs for this case. You see here that we have severe bone loss on both central incisors. And it's in those cases where it really becomes very critical to perform our periodontal probing and bone sounding so that we can pick up where we still have healthy attachment levels. And this is what we're doing here. And we can immediately see that we still have healthy attachment levels on the mesial aspects of the lateral incisors. And so these teeth are not compromised. We simply have to work on the central incisor position and try to grow bone to the levels that are present on the lateral incisors. So let's look at the case. We have here what we would call a soft tissue volume deficiency. Once I take those teeth out, there's going to be 2 holes left within the soft tissue, and probably not the best time to proceed with the bone grafting procedure. We need to start off with, if not a positive, but perhaps a soft tissue volume that completely covers the defect at hand. And so definitely we can take those teeth out, we can add a connective tissue graft in, but in this case, I felt that taking those teeth out and simply filling the site with PRF is gonna be adequate. And we're not mobilizing any flaps here. We're not advancing the buccal, we're not advancing the lingual, we're simply letting that fill in with secondary intention. And we wait about 4 to 6 weeks in this case. And this is the soft tissue conditions that we see before we proceed with our hard tissue procedure. And here we see that we have, you know, everything is fully covered. And so that soft tissue volume deficiency is no more present. And we go ahead and flap the area, and you can immediately see that, again, we're dealing with a moderate, I would say a moderate vertical deficiency in this case, maybe a little bit on the severe end. But again, it's a true vertical deficiency. We have both a buccal and a lingual component. But when we look at the interproximal height of bone on the lateral incisors, we can grow the bone back to that level, basically. And, you know, based on what we've discussed so far, this is going to be a titanium mesh case in my hands. And again, in those cases, I'm not relying on bone substitutes that much anymore. I'm incorporating at least 50, 60, 70% of autogenous bone in those cases. And really it's not about forming the right quantity of bone, but it's really goes down to the quality. And when you go back in at 6, 7, 8 months post-op to place your implants, you can really appreciate those cases where you've added a sufficient volume of autogenous bone. And so again, here you see the mesh fixated in position. This is a thinner mesh than what we saw before. And so tacks are usually adequate to stabilize this type of mesh. We're using autogenous bone harvested from the tuberosity. In this case, mesh is also stabilized on the lingual aspect. And here you can see the closure of the site. Again, we advance those flaps up as much as we can, get that double layer closure. And here you see the post-op CT scan. And so you look at the cross section and you can appreciate the amount of vertical bone that we're trying to grow in this case here. Now, one complication, you know, as we all know, that is very, I'm not going to say very common, but it happens with titanium mesh, is going to be exposure. But, you know, I know that you know the study as well that I'm going to talk about here. And this is a very nice study. It's a nice systematic review that talks about titanium mesh exposures. And not only are titanium mesh exposures easier to manage compared to other non-resorbable barriers, but they're very easily avoidable. Not just because you use titanium mesh doesn't mean that you're going to end up with a titanium mesh exposure. And thankfully, in this case here, this is at about 6 months post-op where we have this exposure. But this is what I call a very low risk exposure. You know, we don't have, the margins of the mesh are not exposed. The area that's exposed has soft tissue grown from underneath. And so we really still have a soft tissue seal, even though the mesh is exposed. But I'm not going to say that, you know, when you have a titanium mesh exposure, it doesn't affect your result. No, it's going to affect your result. You're probably going to have a little bit less bone formation in that particular site. But again, that does not mean that it will necessarily affect your plan or your ability to move forward. But again, when moving forward with this case, we need to figure out how we're going to manage this soft tissue deficiency. I'm not going to try and suture those edges to each other, because if I do that, I'm essentially creating a mucogingival defect. And so we open up the area and we're reflecting the flap as is. The flap that's reflected here still has the hole or the dehiscence present in it. But you can immediately see that we've managed to grow an adequate amount of vertical bone to place our implant in a restoratively driven manner. Here you can compare pre and post for this case. And again, you see the beauty of incorporating autogenous bone and the nice blend that you see between the native bone and the grafted bone. And so implant is in position. Here you see that we have good quality of bone, not much of a pseudoperiosteum in this case. And then to manage the dehiscence that we've had within our flap, we're gonna place a connective tissue graft on the labial aspect. And I'm simply gonna maintain the same hole that we've had in this flap. We're simply gonna maintain this as is, and we're gonna let our graft be exposed through that dehiscence within the flap. And when this heals up, you see that this area where the graft was exposed keratinizes as normal. And what we're left with is a nice mucogingival line that has not been distorted in this case. Now we let this implant heal for about maybe 3 months. And this is going to be a cantilever case where we're using one implant to replace both centrals. But we let this site heal. And we go back and perform our second stage analysis as we've been talking. And we look at this case here. Well, we have excellent KG on the labial aspect. I don't really need to touch that at all. But look at the lingual aspect. And you see where the mucogingival line is. And we do a little roll test as we've all been taught in our residency programs. And we see that this mucosa rolls up to the crest of the ridge. And this is something that we need to manage at our second stage procedure. And based on these soft tissue findings, my plan is to proceed with the second stage surgery with a lingual free gingival graft. And so you can see the incision design. We're simply following the lingual mucogingival junction, push all that mucosa apically and uncover nice sound periosteum. We're using a full thickness access to uncover the implant. And then we're harvesting a very small and thin free gingival graft, and we're suturing it on the lingual aspect. This is the type of healing that we can see at about, this is 2 to 4 weeks post-op. I'm not really sure. And this is the time where we can start provisionalizing the case and reshaping those soft tissues to obtain a nice emergence profile, which is what we see here. And this is basically how we finish the case. We have nice emergence profile for 2 central incisors, and this can now be a predictable restorative case for our restorative colleagues. And so, we've been talking about implant site deficiencies throughout this lecture. And I'm going to end with a few conclusions, which is really a summary of all what we've talked about and how to manage these cases predictably and in the correct sequence. Well, managing implant site deficiency is a complex process. It does not necessarily mean one bone graft or one soft tissue procedure. It may involve several procedures. It's very important to analyze these patients systemically and at a local level so that we can decide what procedures are needed. And after we decide what procedures are needed, we need to follow the correct treatment sequence in that we can sequence these procedures in the right order so that we set ourselves up for success at every stage of the treatment. And so, I'm going to share a few photos here of, one of both yours and mine's favorite meetings. And these are all from Dental XP meeting. And, hopefully we're all going to be back there very soon. We're all going to be, meeting each other at meetings very soon. In the meantime, we can all simply enjoy this nice age where we can all interact, share, and discuss online. And with that, I would like to thank you again for having me. It's been a real pleasure. Thanks, Omid.
Thank you, Ehab. It was our pleasure. Listening to you all the time is just amazing. Very comprehensive presentations all the time by you. For all the audiences interested in Ehab's presentations, also he have amazing ones at dentalxp.com. on bone grafting, on soft tissue grafting, on partial extraction therapies. I had the pleasure to have, as one of the contributors in the Iranian version, Persian versions of partial extraction therapy book, Ehab's clinical cases. So it's just amazing every time we listen to your presentation. And again, thank you for accepting this invitation. So,
it's my pleasure.
I want to ask these questions because I really want to know your idea. And by the way, you have a very beautiful logo. I just wanted to mention that.
Thank you.
I really like it.
Again, this was one of my projects in the past 2 weeks. So
really good. Big like.
Thank you.
What's your because I saw it in your cases, and what's your preference in doing soft tissue grafts? Sometimes, in most of the cases, we prefer to do the soft tissue grafting after bone grafting because we are a bit worried about scar formation and not being able to easily having a tension-free flap and release the flap. But in some cases, as I considered your first case in the lower anterior, you did the soft tissue graft first, the case that you had the pheromone pulled from the lingual. The soft tissue graft first, and then the titanium mesh augmentation. I wanted to know when usually you decide to do the soft tissue graft first or do it at the reevaluation of your bone grafting.
Yes. So, to put it in a really simple way, my preference is always going to be performing the soft tissue at the time of second stage surgery, when everything is said and done and I can better visualize where I need to graft, buccal, lingual, prestal. What do I need to graft? Is it thickness? Is it kg width? Is it vestibular depth? But if I'm faced with a defect, a bone defect, where I need to graft that bone defect and I feel that the soft tissue conditions will not allow me to be successful at doing that. And when I say will not allow me to be successful, I mean will not allow me to gain predictable primary closure. Then these are the cases where I'll have to intervene first with a soft tissue graft procedure to set myself up for success in the bone graft. And just because in these cases, I did the soft tissue graft procedure first, that doesn't mean that I won't have to do another soft tissue graft procedure in the end. You know, there is, I'm sure, a lot of clinicians out there right now are shying away from, you know, all this regenerative surgery, all this soft tissue and hard tissue surgery. But I really want to quote one of my, you know, big mentors here, which is Craig Mish. He has a recent publication out, which I love the title of. Just from the title, you can grasp the concept. And it's not a graftless approach. It's a graftless approach. You know, so even though we're doing all these mucogingival and hard tissue augmentation procedures, we're still trying to keep it to a minimum. We're still trying to reduce the severity, but without compromising the quality and predictability of the results.
Yeah, I totally agree with you. And one of the other interesting things that I wanted to ask you, I mean, like you, I'm also a great fan of titanium mesh, but one of the questions that usually audience in the lectures or participants in the courses ask from us about the titanium mesh and that worry and concern they have about the exposure. I want to ask you that what is your preference in choosing the type of the titanium mesh? About the thickness, do you prefer the flexible one or more rigid ones? And what's your main consideration in choosing the titanium mesh? I'm asking this question because I can safely say that you are among, top 3 people I know doing beautiful titanium mesh cases.
Thank you.
I mean, I truly am saying it because it's not easy. You know, people should know that it's not easy. It takes skills, it needs expertise. So just to give an idea to the audience, what is your main considerations in choosing the proper titanium mesh?
So that's actually a great question, because I feel that this is something that's not talked about, you know, very often. And personally, I'm using 2 different types of meshes. One is a thicker type, which I showed in the first case. This is 0.2 millimeter thick. And one is a thinner type that I showed in the last case, and this is 0.1 millimeter thick. I would have to say that I'm using the thicker one in larger cases, in less contained cases where I'm depending on the mesh, you know, to a large extent in this rigid graft stability. I'm using the thinner one in defects that are more contained, defects that have more walls that can support my graft, and I'm not only relying on the mesh. The thicker one is really more difficult to handle. It depends on your preference, but the thicker one, you really need, as I'm sure you know, you need to shape it outside the mouth and then place it within the mouth to the correct shape. The thinner one, it has the advantage in that you can tack it on one side of your defect and then start shaping it while it's within the mouth. And I feel that this is an advantage for it. But in terms of the amount of bone that you get or the quality of bone that you get, I don't really see that there's a difference as long as your mesh is stabilized, you know, and an unstable mesh is a silent killer. So as long as your mesh is stabilized, I think both work very well. I think if I was to recommend something to all the clinicians out there, it's going to be to try both, you know, try both and see what works better. You may find yourself using only one of them. You may find yourself using both of them. And one advantage, as I'm sure that you know already, of titanium mesh is the economic price. You know, you can get a sheet of mesh that you can use for 8 to 10 procedures that costs $150. You know, compare that to other non-resorbable membranes out there.
Yeah, I totally agree with you. And the final question is that what's your idea about using those type of titanium meshes that can be fixed on top of the dental implants with something called flat abutments? do you prefer to do the augmentation at the same time of implant placement? And if so, do you prefer to use these type of meshes or other techniques?
I would have to say that I do quite a bit of cases where implant placement is simultaneously done with the bone graft.
Mm-hmm.
But I find that most of my cases that are like that are going to be with a bone graft procedure like GBR with a resorbable barrier. You know, something that's low risk. When treating the defects that require something as rigid as mesh, I find myself treating the defect first, building the bone first, and then coming back. Now, with regards to those meshes, I've seen people build awesome bone with them. You know, Isaac Towell has some great cases using this mesh. My biggest problem with them is the inability to stabilize that mesh apically, which I feel can be a big risk when you have a mesh that is stabilized to the implant at the crest, but apically it's flapping back and forth. That can completely kill your graft. But you know, we've discussed this several times before. If you use one that's big enough, you can probably add a small tack at the apical part of it, and that'll help out a lot. So, you know, again, I'm a guy that, you know, I like to go out, learn new techniques. For example, the Corey technique, you know, I learned this from Howie, and then after that from Frank. And this is something that I haven't been doing for too many years. Yeah. So I think that, you know, we need to go out, learn new stuff, you know, keep it exciting, keep the passion going. But like I said in the beginning, you know, pick a few things, make them your own, practice them until you become very efficient at them.
Totally agree with you. Ehab, thank you so much for your time. Always a pleasure talking to you. And thank you again for accepting this invitation. I'm pretty sure everybody have enjoyed your amazing presentation, and really looking forward to see you soon, and also very soon welcoming you in my country, Iran.
I appreciate it very much, man. And thanks again for having me.
Thank you so much.
Have a good day.
Take care and stay safe. Bye-bye.
Thank you very much. Bye-bye. Thank you.